I'm a second year adult nursing student here at the University of Southampton, and I absolutely love it. Hi guys! My name is Claire, and this is my first ever YouTube video. I'm a little bit nervous, but I've been thinking about it for a long time, so I thought I'd just suck it up and get started. Today I'm going to talk about what student nurses do on placement, because if you've never gone to a clinical placement before, you might wonder what actually goes on throughout the day and what a daily routine looks like. So I'm going to start off by telling you about my daily routine on my last placement, which was a trauma and orthopedics ward. We had a lot of elective patients, so people coming in for knee and hip replacements, and then we also had traumas as well, so it was a really good variety. I really liked that placement because I got some really good hands-on experience compared to other placements where I'm more sat back. If I hadn't mentioned, I'm a second year adult nursing student here at the University of Southampton, and I absolutely love it. So the placement I just finished was my P3, so placement 3. So now I'm on to placement 4, which starts in February. So let's just get started on my daily routine in a trauma and orthopedics ward. This can also be brought into any placement because most wards will be a lot similar as well, but this is just my personal one, what I do on a typical day of placement. So firstly, I get up at 6 a.m. I turn on my light, I get ready, I have breakfast, and then one big thing that I made a change recently is cycling to placement. I'd highly recommend that compared to getting the bus, which costs here in Southampton £3 for a return. Doesn't seem like much, but when that's every day, that's quite a lot. Obviously taxis completely out of the equation. Don't have a car because I'm actually Irish, so it's back in Dublin, not very helpful. So yeah, cycling just seems like really fitting. So my placement is about a 45-minute walk, so a 15-minute cycle, so that saves so much time in the morning. So I cycle to placement, and then when I get to placement, I obviously don't cycle in my uniform because that wouldn't be very nice being in a sweaty uniform all day. So I cycle in gym gear, then go to one of the staff toilets, get changed into my uniform, and then I'm ready to start my day. So typical day starts off with handover first. Actually every day at placement starts off with a handover first. So this is where the night staff give an update to the day staff about what happened during the night. So you get pages and pages of patients, depending on how much is on your ward, and you go through and you pick out the patients that you're going to be looking after that day, and you kind of focus more on them, but the other patients that you might not be looking after solely that day, you also take down their updates, because if anything happens during the day and one of the nurses leaves to go to lunch and you're asked to look after that bay as well, you need to know what's going on, so that's really important. Then after that, obviously since we're students, or I'm a student, maybe you're a student too, and if you are, I hope your course is going really well, you're allocated somebody to work with. So this might be your mentor, or it might be your buddy mentor. So my mentor was a sister on the ward, so she was always in charge and always really busy, really nice. And then my buddy was a staff nurse, so she was a lot more like hands-on in the bay and stuff. So depending who was on that day, I go with either one of them, or some days if they weren't on, I'd just go with another nurse who was willing to take me on that day. And then not so much in P3, but definitely in placement 1, you were kind of shadowing them, especially at the start of your placement when you don't know where everything is on the ward, you don't know the ward routine. Obviously you have to kind of go around with them a little bit more. But because it was P3, the first 2 days I actually went around with a healthcare assistant, which I'd never actually done before on a placement. And at the start I was like, oh, okay, will this be helpful and everything? But it actually was amazing. And as the sister says in my ward, they're the eyes and ears of the ward. They know everything that's going on, especially the senior ones that have been there a long time. They just know everything. So ask them, write down all the passwords to the store cupboard. I'd recommend that. The passwords to the medication cupboard. So you don't have to keep being like every day, what's the passcode? You know, and they keep being like, oh, 1, 2, 3, 4, or, you know, whatever it is. So I'd find that's a really good piece of advice. So then you're allocated who to work with. So the first thing you probably do in the morning is on the trauma and orthopedics ward. It's to see if you've any post-ops from the day before. So post-ops, I'd always check their blood pressure and stuff before you give, you know, amlodipine, things like that. For blood pressure, heart rate, I'd always check if they're high enough to give it or too low to like hold it, or ask the doctors, things like that. So if they're day 1 post-op, we used to always check the obs before any medication. If they've been day 2 or 3 post-op and they're doing fine, then we wouldn't check their blood pressure or anything before giving the medication. We would look on the iPad and see what the previous blood pressure or heart rate was, but we wouldn't take a new reading, you know, a new full set of observations. So yeah, that's just about post-ops. So this is obviously quite specific to a trauma and orthopedic placement. But in normal placements, it might be poorly patients. So if the night staff handed over that there was a patient who had low urine output, high heart rate, low blood pressure all night and was really poorly, and the outreach team came and everything was like going on, then I would say to check that a set of observations before you give, you know, all the medication, because it is just important to know. Because let's say if they had a really low blood pressure and you gave a blood pressure tablet and it went crazy low, or you get frusemide and it went really low as well, then that's like kind of down to you, because you should have been the one to check. Well, you and the nurse, you know. So then you do the medication round. So this involves going around, obviously assisted. Sorry. So the medication round involves going around with the nurse you're allocated with that day and doing all the medication rounds. So it's going around to each patient. In my hospital I was in, we have a system called JAX. So that's an online system where you chart all the medication and everything. So you go to each patient, you see what medication they have, and then you either go to their locker where their medication is stored away with the key, and you get out their medication. If they have a lot of their own medication from home, then you use that and you give the medication out from there. And then I can't stop yawning, sorry. And then you use the drug trolley as well for like the analgesia, and then the morphine and fentanyl and all that is obviously stored away in the CD cupboard, control drugs. So you'll need 2 registered nurses to get that out. So obviously we're not involved with that at the moment. So after the medication round, you need to be involved in personal care with your patients. So although the HCAs do a lot of this, us as nurses, it is part of our role. And I actually really like it because it's a time to talk to patients, see, you know, especially on a trauma and orthopedics ward, how they got their injury, how they broke their leg, things like that is really important, because it's just making that bond with the patient and making them feel like you're the trustworthy person, you know, they can talk to you about anything. So that's really important. So you can either help a HCA if it's an assistance of 2 wash. So if it's someone who's really poorly, or like a bigger lady or a bigger gentleman who might need assistance of 2, then you can help the HCA, or you and another nurse can go in. But most people would just need assistance of 1 to maybe do their back or do their feet, or do where like they can't, you know, mobilize with their maybe broken elbow or broken shoulder or anything. So that's really important. So you need to help them and make sure that everyone washed and cleaned, and preferably sitting out of bed for breakfast. I really like to do this because it just gets them starting off the day right. It gets them, you know, sitting in their chair, ready for the morning, instead of, I feel like, you probably know yourself, sometimes when you're in bed you feel lethargic, you feel like, oh, I'm so tired. But once you get out and you actually sit up, they're like, oh, I feel like a lot better. So I think that's a really good way of getting them out of bed to have breakfast. It's just that tiny little thing taking the time and energy to get that person out of bed, sitting in their chair with their table in front of them for their breakfast instead of lying in bed eating breakfast. I really like doing that. So then, after helping with the HCAs, I always like to do my morning documentation quite early. Not all of it, like not my writing notes, because obviously at this point it's probably only 9 a.m. and nothing much has happened with them and you don't really know what's going to be going on with them in the actual morning. But I like to complete things like fluid charts, VIP score sheets, so to do with cannulas, see if they're okay, catheter charts to see why they're still in, when they were put in, if they need to be taken out. And then we also have a thing called turnaround charts. So this is basically when a person can't mobilize themselves in the bed and you need to, every 2 hours, you need to move them into a different position. This is to prevent pressure sores and pressure damage and just anything on their sacrums or all their pressure points. So like their elbows, any bony parts basically. The back of their heels, make sure they're always elevated on the pillow unless doctors say otherwise, because of maybe a knee replacement, they don't want them elevated, or depending on what they've had done. After that, a lot of the patients on my ward were on IV antibiotics. So this is a really good chance for me to improve my IV skills and to do lots of drawing up, because in the bay I was in, it was 6 patients and about 5 of them, let's say, were on IV antibiotics. So this is a really good opportunity to start drawing up all the different types of antibiotics. You might have like ticaplanin, which I didn't even know about before this placement. It's often used if people are allergic to penicillin. Then we obviously had the ones with penicillin, so like Fluclox, Camoxiclav, things like that. So that's really interesting to find out all of the different ones. Or vancomycin, when you have to get the vanc levels and things like that. And these words might sound like gobbledygook to you, and they did to me too, trust me, before this placement. But now I can safely say that antibiotics, I feel a lot more comfortable with them than I did. Obviously there's ones I still don't know, and you obviously have to double check everything, but it was a really good experience to be able to draw up a lot of them, to have nurses looking at you and be like, oh, do this instead, oh, no, don't do that, you're gonna give yourself a sharp injury, things like that. I found really helpful. So I definitely recommend, if you can, to get a lot of experience with IVABs or IV antibiotics before you qualify, because you don't want to be a newly qualified nurse and be like, how do I do this? That would be a scary situation. So try and get as much practice as you can, I'd say, in placement. Obviously, if the nurses are willing to let you. And I wouldn't say that I got much experience at all in placement 1 and placement 2. But towards the end of placement 2, a little bit, my nurse was like, oh, you can try 1 in here, there. But by placement 3, the one I just finished, I was doing maybe 10 a day, so that it really, really gets your skills good. So then it becomes, let's say we're at the 10, 11 point now, maybe 11 a.m. So at this point, sorry, I can't stop yawning. Okay, so we're at the 11 o'clock point. So at this point, I would recommend taking observations. So this is, your blood pressure, your heart rate, your respiration rate, your temperature, and your saturation oxygen levels. So this is really important, and we did this between 10 and 11, but it was more towards the 11 side. So this is the first time that most people's observations have been taken since 6 in the morning. So that's a good few hours they haven't had any blood pressure or anything taken. So during this time, it's really important to find any findings that you find that might be obscure. So low blood pressure, let's say, if it's 91, 88 systolic, you should report that to your nurse in charge, because especially with post-op people, they're often prone to low blood pressure and it can make them feel really weak and dizzy and just they don't want to get out of bed, or they might fall back and faint. We've had that a lot, so it's really important to report these findings and not just be like, oh, okay, they've low blood pressure, be proactive about it. Be like, I know this isn't normal, so what am I going to do about it? And then you should be like, okay, so I should tell either my buddy and she can decide what to do. Or if you think it's severe enough, if it's really high blood pressure or really, really low, then I'd say, go to yourself, think to yourself, go to the nurse in charge and just say, I've just done observations on Lady X and she has blood pressure of whatever, and tell them, because that's really important, because they want to know, trust me, and you're doing them a favor, because otherwise they're out of the loop with what's happening with the patients. So after taking the observations for all the patients you're looking after that day, so it might be 6 to 9 on my ward, or sometimes a little bit more if we were short-staffed, then it's important to think about the people that are going home. So I like to make a bit of a plan with my patients. So let's say if we have a post-op day one, obviously they're not going anywhere, they've just had their operation yesterday, they're staying put. Then we have people who might be day 2, day 3, still not ready to go home. That's fine, we'll still look after them, they're perfect. Then we have people who are medically fit for discharge, they say, MFFD, medically fit for discharge. And these are the people that do not need to be in hospital anymore. So it's really important to make them a priority to get them home, because it's not fair on us and it's not fair on them to keep them in hospital for longer than they need to be. You know, they have families to get back to, they don't want to be in here forever. As much as nice we are, they don't want to be in here forever. So it's really important to prioritize them and, you know, do things for them that will help them get home quicker. So get their medication ready to take home, so their TTOs, their HMR, you know, things that the doctors have to sign to say, yes, they are medically fit, yes, they can go home. And often there's delays with the doctors or the pharmacy, but that's not their fault. Everyone's super busy and we understand. But it is just a thing to keep in mind, because in my first few placements, I never would have thought about people like going home or how I would get them home. You know, it always seemed to just happen. But on this placement, I found that was one of like my learning objectives, to get more involved with patients that are going to be discharged, because it is a really big part of nursing, especially in a trauma and orthopedic ward, when there's such a high turnover. Like the maximum, you know, our patients would be there with maybe a week at maximum, if not 2 or 3 days. So it's quite a large turnover. So therefore, you have a lot of people going home all the time. So it's really important to think about that and be like, okay, they have families to get home to. How can we make this happen? Okay, so I probably should have mentioned this a bit earlier, but this is about people who are going to theatre that day. So if you come onto a shift and you're told that patient Y is going for theatre at 4 o'clock or whatever, they'll be made nil by mouth. So they won't be able to have anything to drink or eat until they go to theatre. They might be allowed clear fluids until a certain time and food until a certain time, normally the night before. So it's really important when you come onto your shift that the catering staff know, you know, everybody's aware that this patient is to not have anything to eat or drink from now on. Because this often happens, that there's confusion between either the patient doesn't know themselves quite what is happening, the other members of staff are confused, they're like, oh, are they going, are they not, you know, things like that. So it's really important, if they are meant to be nil by mouth and going to theatre, that they remain nil by mouth, because otherwise it just messes up the whole, you know, system, and the anaesthetists and surgeons do not like it if they eat and stuff. So also, if they're going to theatre that day, they need to be consented. So it's only the anaesthetist that comes up and consents them, or the surgeon. So this is basically it is the surgeon, sorry. This is when the surgeon comes up and tells them, this is what, you know, this is the surgery you're going to have, these are the risks, these are the complications that might occur, and things like that. And they have to consent to it. So they have to sign this yellow piece of paper. Well, in my hospital, it was a yellow piece of paper. And they have to consent to that operation, because they have to know everything that's happening, and it can sometimes just either worry the patient too much or put them at ease, depending on what the surgeon says to them. Because obviously there's risks and complications to every operation, so it's that they need to be aware about that. Then also, we need to do a patient checklist. So this is another sheet that's filled out by the nursing staff, and I've actually done a few, which was really handy and really useful. So it just is basically like if there's any prosthetics, any false teeth, any glasses, hearing aids, things that the surgeons may need to know about. So that's good to get involved with doing that, because plus you learn more about your patient and the whole picture of them, and it's just a useful skill to be able to do. Another thing, I presume this is the same in every hospital, but they need 2 patient ID wristbands to go down. So it's normally one on one hand and one on one ankle. Obviously, if they're having an operation on that leg or that ankle, you don't put it on that ankle, you put it on the other one. Or if it's their 2 legs are involved, then 2 on either ankle, on either wrist. Sorry. So then after you've done all that, this is probably about 1 o'clock now. So now it's time for afternoon medication. So this is normally a lot of paracetamol, analgesia, and some other, medications that people might be regularly on. So you go around with the nurse you're allocated with, and obviously all drug rounds should be supervised when we're students, because, that's how we do it. And then we go around and we give all the medication, and at this point, a lot of the, slow release morphine tablets or things like that might be due, or people might be in a lot of pain from their surgery the day before, things like that. So we'll give out analgesia, so it might be like oral morphine, fentanyl patches, things that they're prescribed for them, maybe on their PRN side, so when needed side, or there might be stuff like cyclizine and ondansetron, which are really good for anti-sickness. They might be on the other side as well. So if somebody's feeling really nauseous, and to prevent them vomiting, we'll give that maybe IV urine a tablet before they feel like they're going to get sick. So that's really useful. So throughout this time, we need to make sure our turns are maintained. So that's what I was talking about, our turnaround chart. We need to make sure that was maintained every 2 hourly up until this point. We also, at this point, normally after the afternoon medication round, before I go for lunch, I like to get all my documentation done. So all my writing about this morning. So what happened, the patients got their medication as charted, are their observations stable, have they been visited by family, what's been going on, what did the doctor say, are they awaiting an x-ray, are they awaiting a CT scan, an MRI, what's going on with them, making a note of it in their folder at the end of their bed or wherever your hospital might keep them. So at this point then, towards the afternoon, things start to slow down a bit. So you've done your washing, you've done a lot of medication, everyone's sitting out in bed now, people are getting visitors in sometimes, everyone's washed, clean, dry, dressed, all of that's done. So at this point, I like to take time to go for walks with patients, or just, take time to talk to patients if you have time, which a lot of the time in the afternoon on my ward, we did have a lot of time to, go for a walk up and down the corridor with a patient who had a hip replacement. So going for walks with people that had a hip replacement, because this is obviously a big ordeal operation for them. They've just had a total hip replacement. It's not their hip anymore, so that's a big deal to be able to start walking again and everything. So it's really important to encourage them, along with the physios, who obviously do an amazing job getting them back to their feet and everything, but obviously all making sure that you're okay to bring that person on a walk. The physios say it's okay, because you don't want to whip someone out of bed and they're like, no, they should be on bed rest and things like that. So that's really important. Okay, so then sorry, my phone keeps going off. So then after whatever you do during the afternoon, so walking with patients, giving medication, doing your documentation, there's another drug round in the evening. So bear in mind, a lot of hours have passed in between this time, and depending on the ward you're on, there'll always be jobs to do, so don't worry about that. Just remember to take initiative, because I find I used to be really bad at that. I'd always be like, oh, what do you want me to do next? Well, if you see a job and you're like, oh, that can be done, I can do that, just go and do it, as long as it's safe and as long as you know, it's in your ability, go do it, because trust me, a lot of nurses really don't like when students are always like, what's next, what can I do, or like, you know, just follow them around all day. So then it's important to do more of your documentation. So if you're on a long day, it's important to document what happened in the afternoon as well as the morning. So you've already done your morning earlier, and now it's important to document what happened in the afternoon and late afternoon. So if they needed, you know, anti-sickness, or if they vomited, or if they were seen by physio, if they're discharged by physio, if they went for a CT scan, you know, if they had all those scans that they were waiting for, you know, things like that. It's important to document it so the night staff and the next day staff know what's been going on that day. So we're coming towards the end of a day, and I know it sounds really, really long, but trust me, it's amazing. So then the last thing I do before I go home is I try to hand over my patients from that day to the night staff. I might only hand over, at the start I was handing over 2 patients, and then I worked my way up to 6, which was really amazing. I was really happy they allowed me to do that. And then you hand it over to the night staff, and they often ask a lot of questions because they obviously have to know a lot of information depending on like what happens the night, but they're also going to be the one handing over to the next day. So they need to know, you know, when they're going home and stuff like that. Excuse me. Even though they might not be going home during the night, if that makes sense, they still need to be aware of when people are going home. So then I hand over, and then we all, you know, say goodnight to the night staff, and we say we'll see them tomorrow or whenever we'll see them. Then I get back changed into my gym gear, get on my bike and cycle home. So I know this probably is quite particular to trauma and orthopedics, this day in the life of a, you know, a student nurse, or what you do on placement, but you can take things out of it and you can apply it to your own placement. So I really hope that this is helpful. My first video is completed, it's crazy. So yeah, I hope to see you soon for a lot more. Bye!